said, it is the 7th webinar in the series. And as we all know, GAPIO is a non-profit organization established in 2011. Padma Vibhushan Dr. Pratap C. Reddy, chairman of Apollo Hospitals Group, is the founder president of GAPIO with the vision improving healthcare worldwide. With the aim to bring together healthcare professionals of Indian origin in the world on one platform. In these webinars, our endeavor is to bring the expanded scope and the latest advances in the field of physiotherapy and how the multidisciplinary approach has helped patient care. So as I said, today's webinar is on chronic pain management. Certain little facts before we hear the stalwarts in pain management is we all know pain is the 5th vital sign. And it's a major complaint of people to seek medical help. 1 of the 10 adults, they suffer from chronic pain. With all in our scenario, we all measure pain with various pain scales, which is visual analog scale or NPS and various other formats. But that's not the only thing. Pain assessment and measurement, we all know, is a very, very important measure of the patient well-being. Right? If we are in pain, we may not like to even talk, to meet people, or to socialize, but the moment pain is less, we are back to our best being. So today, it is our endeavor to share the knowledge through lined up sequence of 4 presentations from prominent champions from the medical and the physiotherapy field to discuss an important topic, as I said, which is chronic pain management. They will also shed light on latest advances to help ignite a healthy discourse for clinicians and academicians in the Indian community for further enhancing their scope of practice and patient care. I hope we have from the various countries, we have our speakers and so would be the attendees. So I welcome everybody. Without taking much time, I would introduce our first speaker, who is Dr. Adrian Lau, an eminent, renowned pain management specialist with many books to his credit. Dr. Adrian earned his undergrad, master's degree, and PhD in physiotherapy from University of Stellenbosch in Cape Town, South Africa. He is an adjunct faculty member to St. Ambrose University and University of Nevada, Las Vegas. Teaching pain science, Adrian has taught throughout the US and internationally for 25 years at numerous national and international manual therapy, pain science, and medical conferences. He has authored and co-authored over 100 peer-reviewed articles related to spinal disorders and pain science. He completed his PhD on pain neuroscience education and is the director of Therapeutic Neuroscience Research Group, an independent collaborative initiative studying pain neuroscience. He's a senior faculty pain science director and vice president of faculty experience for evidence in motion. I contacted him that we really want to hear you, though he was occupied somewhere, but he was kind enough to share his video with us. So without taking much time, we'll start the first video which he shared with us. So
welcome everybody. This is Adrian Lowe, and I want to welcome you to this conference. And I'm very, very excited to start off this conference talking about pain neuroscience education. The world is in pain, and no matter where you look at it, the World Health Organization, you look at the United States, in any part in the rest of the world, you'll know that a lot of people are currently suffering with pain and disability. COVID, unfortunately, didn't help us with any of this, and we know there's major problems right now with pain, specifically chronic pain, mental health issues, behavioral health issues. And so as healthcare providers, we find more and more people seeking our care and our health. The good news today, I'm not a negative person, I'm actually very quite positive, is that there has been an absolute total pain revolution. I am super proud of the work that's been done all around this planet in different parts of the world, different research laboratories. My team, I'm very proud of. We've learned more about pain in the last 10, 15, 20 years than we've ever learned in the history of mankind. Since the evolution of brain scan technologies in the early 1990s, we've learned so many cool things about pain. Learning about the pain neuromatrix, ion channel expression, glial cell expansion, etc. All of this teaching us more and more about pain, and that is so nice. The cool thing about all of this is, yeah, we learn about pain, but what does it do? And that is really what my lecture is here about this afternoon and this morning. And that is that we have a mandate. If we're learning more about pain, we must take this knowledge and apply it to our clients. As a clinical researcher, I think this is absolutely vital. Yes, we learn a lot of things, but we must ultimately be able to apply it to our patients, to our clients to improve their life. Can we change things? I think everything I've seen in pain neuroscience, neuroplasticity, bioplasticity tells us there is definitely hope. We can definitely impact it. We've seen it in all our research. We can definitely help people accordingly. And I would encourage you to take on pain science and learn more about it. I also need you to understand that pain science isn't just for chronic pain. I know we always talk about chronic pain, and chronic pain in specifically typically orthopedics or outpatient environments. But pain is pervasive, it's everywhere. Pain is in pediatrics, it's in sports medicine, it's in geriatrics, it's in neurology, it's all over. By the way, pain neuroscience education, we have now published quite a few papers to show it even works really well in acute environments, early environments like surgery, before surgery, after surgery. Well, we built a middle school program for middle school kids to learn more about pain. And when they go through it during the school year, they actually use less pain medicine and they attend school more. So really a lot of reasons why we want to take pain out there. Yes, we've built it for chronic pain. It was designed for chronic pain, but it is such an opportunity to change lives so much along so many different pathways. Pain neuroscience education in the most simplest way. In the United States, where I practice, we every day 177,000 people come to physical therapy for back pain. When they walk into our clinics, we teach them everything about the back. Good disc, bad disc. Good core, bad core. Good muscle, bad muscle. But we teach them nothing about pain. Louis Gifford, who is actually shown here, was the pioneer. He was the one that started this revolution, by the way, this idea of teaching people about pain. When people come to us with back pain, neck pain, knee pain, shoulder pain, yes, we can teach them about the neck and the back and the knee and the shoulder, but we should definitely teach them more about pain and how pain works. And all I will tell you today is the research is overwhelming. We now have almost 24 systematic reviews and meta-analysis, some of the highest forms of evidence we have to show when a person walks in, meets a clinician like me and you, treating somebody, teaching them about pain, their life is way better for it. Their pain goes down, their knowledge goes up, their disability is better, catastrophization goes from cup half empty to cup half full, the fear goes down, they move better, etc. In contrast to some of the medicine that's out there, you'll see that like gabapentin and SSRIs, these are chronic pain drugs that we use, that pain neuroscience education is better than that in terms of its outcome. It has a better numbers needed to treat. It actually physically works really, really well. The good news is it's safe. It can be done by everybody, and we're super, super excited about this work. And then finally, just understand that pain neuroscience education isn't the end all be all. So what I mean by this is we don't just teach people about pain, we then blend it with manual therapy, exercise, stretches, all the stuff. The stuff you do every day as a physical medicine rehab provider is critical in making people better. What pain neuroscience education does, it calms you down, reduces fear, and allows you to move. So as I finish up real quick, there are only 4 things a patient wants to know from you Monday in the clinic when you see them. What is wrong with me? How long will it take? What can I do for it, the patient? And what can you do for it as a clinician? If you can answer those 4 questions, the nervous system beautifully dampens down and helps people accordingly. I hope that was helpful. I hope you have a great conference. We're super excited about getting our message out to the world and also taking pain science to the masses and where people need it.
So I believe he set the ball rolling that yes, there are these simple, he's put it such a vast subject which has affected maybe at some point in time in life to all of us in such a small thing that these 5 questions, if we come across and if we answer or we relate to it, I believe it can really help patient to reduce the pain. So I really thank Dr. Adrian Lau for his insight in the subject. And I believe you all will agree that his various points, what he spoke, they resonated well with all of us. Now we have Dr. K.J. Chaudhary, who is pain specialist, a senior consultant, neuroanesthesia and pain management in charge pain clinic in the Prastha Apollo Hospitals, New Delhi. He is life member to Indian Society of Study of Pain, Indian chapter of International Association for Study of Pain, co-founder, life member, and two-term president of Indian Society of Neuroanesthesiology and Critical Care. He is life member to World Federation for Neurorehabilitation, first recipient of Distinguished Professional Award by Indian Society of Neuroanesthesiology and Critical Care in 2017, life member and advisor, Neurocritical Care Society of India, founder member, Commonwealth Institute of Acupuncture and Natural Medicine, UK. Now we have this eminent personality sharing his views with us on interventional pain management in chronic pain. Over to you, Dr. Chaudhary.
Thank you very much, Dr. Seema. It was an overwhelming introduction, and I'm glad that I'm here in this community. And can I start? Actually, the last speaker spoke about something very relevant, that the knowledge and the skills that is available, how to make it available to the patient. That gap has to be filled up with the effort of all of us. So I would like to give a brief on what I normally do in chronic pain. My slides I have already loaded.
Share your screen, please. So there's below, it's a green up arrow. Yeah.
I think it has come.
Yes. Yes, we can see. Sure. Thank you.
So there's a lot of introduction being given on chronic pain, but it's important here to know what chronic pain means and what are the various types. That I think the management depends on whether it is a somatic pain or neuropathic pain, a visceral pain. So that is a important know, and that is the difference, that how they present with the somatic pain and visceral pain. And what is our goal? And between you have to treat the pain itself, that is the cause of the pain, but more important to see its impact on a patient's body and mind has to be treated simultaneously. Patient who has suffered pain from whatever the reason is, his body has not been mobile or flexible for a long time, muscles have become weaker. So even if you relieve the pain, that you need to bring him to a level of that he is physical functioning and mobility and able to enjoy daily activities. So that should be our goal, to improve quality of life with least harm. So what I do is, my job is to find out what is the source of pain. That is, we call it pain generator. We give a trial of medications, which is analgesics, muscle relaxants, neuromodulator, antidepressants, physical therapy, and most of the time they get settled down. But if not relieved, then you go do diagnostic intervention pain procedure and reach the pain generator and deposit local anesthetic. And if gives a temporary relief, that confirms that yes, that is the source of pain. And today we have knowledge, skills, and equipments available After clinical examination and the history, we have imaging facilities that can give us, support us to confirm the pain generator along with the diagnostic blocks. And if the pain generator is confirmed, but the pain relief doesn't last, then you make it long-term or a permanent relief by stopping the message from the sensory messages from that areas to the brain through radiofrequency ablation. It's a thermocoagulation of the nerves that stops the nerves conveying the messages. And we are doing it much more now than before. Earlier we used to do chemical neurolysis, but those are not predictable that it can be so selective and the chemicals can overflow to other areas also. And the most important thing is that it should be an interdisciplinary approach that you and us, me, can do good work. And pain scale has been taught, already spoken about, and the continuum of pain, that is what is the first thing to do, and gradually increase with the level of pain therapies. So these are common conditions that we come across every day, and musculoskeletal pain is the commonest one that you and me treat. Backache from neck to low back, shoulder pain, headache, and myofascial pain, joint pain, and all those things. So first thing comes to mind in non-drug therapy is physical therapy. And it is not non-drug therapy, is the therapy that comes in, but mostly physical therapy. You have got natural supplements if required, and massage, exercises, meditation, and cognitive behavioral therapy. I just said we have to treat the body and the mind together. This is your area, and these are the modalities of physical therapy, exercise, ultrasound, and that you know better, and you will explain it more. So my concern is like Dr. Heathen also pointed out, myofascial pain. That is the commonest cause and most neglected or underdiagnosed problem. So you know that almost 40% of the whole body is made of muscles, and that is it contributes a large portion of the body weight. There are muscles that has also covering. They are subjected to a lot of repetitive injuries, causing muscles to be stressed, and they produce trigger points. These trigger points are nothing but contracted knots, nodules, or bands that are very irritable, and that contracted muscles reduce residual blood flow. So the metabolic end products keep on collecting, and that stimulate the sensory endings, causing more pain. And these pains are reproducible. These are not in dermatomal. That means not distribution of particular nerve. And a jump sign is the characteristics of trigger points, that when you press it, a particular under pressure, the patient jumps, and it's like a jerky movement in some other parts of the body also. As I said, the trigger points are very close to the muscle innervation zone, and with the increase in the end plate potential, that means there is near sensitive areas. And there is a neurologic component to stimulation of the muscles at the end point. So trigger points are discrete, focal, hairy, irritable spots located in taut bands and skeletal muscles. That could be cause of trauma or mostly the repetitive injuries like different postures, and that reduce the range of motion. It sometimes manifests as a tension headache, tinnitus, temporal joint pain. There are many causes, but today we see patients, the causes mostly are lack of exercise, poor posture, sedentary lifestyle, and also emotional stress. And those are the stresses trigger the EMG activity in the trigger points causing pain. As I said earlier, diagnosis is based on physical examination, the taut bands. There is no laboratory test required. And these are the, when you irritate or press those trigger points, the pain is referred to an area which is not in the dermatome, but in a distant place. I am going to explain to that. Referred pain is a point that this pain creates a pain in another area other than the where you are pressing it. And this is one of the causes of a lot of headaches, neck pain, and even arm pain. This is, for example, if you palpate, the patient may be complaining of pain in these blue areas in the face. But if you palpate the sternocleidomastoid muscles, you feel nodules and the pain is reproduced. Similarly, in the frontalis or trapezius. The patient is coming not for the neck pain, they're coming from the head and facial pain, but the source of pain is here. So you have to deal with these trigger points here. No need to deal with any of this, automatically settles down. Same thing is scalene muscles. See, I gave a presentation some time back to the Neurological Society of India, and about cervical radiculopathy, which are the other conditions that can mimic same symptoms. So typically the scalene muscles, if you press at the anterior neck, the scalene muscles can produce, you feel the nodule here and the pain goes down all over the arm. But sometimes it can give symptoms of neuropathic pain, but usually it is the somatic pain. Same thing is in supraspinatus muscle. It's very common, causing shoulder pain and lower back, posterior neck pain, and also infraspinatus. Supraspinatus scalene muscle pain is very common. They present with symptoms somewhere else. The same thing is the gluteal pain. It can be because of the trigger points in the quadratus lumborum muscle, gluteus medius, or piriformis. But piriformis, once stimulated, it can reproduce sciatic type of pain. Rectus femoris muscle here, and it can produce knee pain. Tibialis anterior, the patient will come and complain about the pain, which can confuse with the radicular pain. Gluteus maximus also causes pain at a distant place. So what did, to answer Dr. Hiten's question about trigger point injections, if the medications, exercises did not help and the trigger point still continues to produce pain, then you have to use trigger point injection, which involves depo-steroids. So these trigger points and sometimes botulinum toxin, but they are not long lasting. We can give once in an acute pain. So today we have got the equipment facility that you can directly visualize the structures in the soft tissues through ultrasound machine. And this is real-time imaging. So the precise mechanism of action remains unclear about the radio frequency. So once the trigger point injection gives relief, but if it doesn't last, we can use radio frequency ablation to denervate the source of pain. Those are the muscle trigger points. This is how we use ultrasound injections, guided trigger point injections. It's like, for example, in trapezius here, you can see ultrasound that the needle is going there. And you can see that even when you're injecting the medication, you will feel that these hyperdense white areas, they get thinner and thinner. This is what you see the other view. So these are the trigger points that you see and inject. The next common is chronic fibromyalgic syndrome, which is actually a underdiagnosed problem. Patients have pain all over the body, and they are feeling tired all the time. They feel like sleeping. They have mood issues. They get irritable. So this is called chronic fibromyalgia syndrome. It's common in women, and it can produce symptoms like tension headaches, temporary joint disorders, irritable bowel syndrome, anxiety and depression, along with fibromyalgia syndrome. There is no absolute cure for the fibromyalgia, but medication can help and control. So first they have to do relaxations, both physical and mental education. That controls them, and there are ups and downs. Sometimes it aggravates, then you have to give medications. The diagnosis is on clinical basis. There are typical trigger points, tender points in the body, 9 points on each side, 18 points, and 11 points have to be positive when you stimulate them, press with the finger under medium pressure. So that is the only diagnosis. There's no other diagnosis required. In the acute stages, then you can, if the CRP can be raised, that's all. So in general, it requires medication and self-care. And medication includes, as I said, pain relievers, but you have to be very careful that you don't have to give too much of medications because side effects. Antidepressants, particularly duloxetine and milnacipran, they reduce the sensory and both central peripheral sensitivity, so reduce the pain to an extent. So anti-seizure medication like gabapentin or pregabalin helps. The combination of the pregabalin and duloxetine is recommended by FDA. That is only recommended treatment for chronic fibromyalgia. These are the physical therapies, and then I'm coming to the next common one, particularly in the aging population, is osteoarthritis of the knee. And this is a progressive disease that can be driven, the problem may be the cartilage, bone, or there may be inflammation. There are researches going on and are able to identify some biomarkers, and able to soon they're expected to produce confirmation of those biomarkers, and so you can have a specific treatment whether for cartilage, bone, or inflammation. X-ray is done in the standing posture because it's always not that the cartilage can be seen in the lying down position. There are different grades, stage 1, stage 2, stage 3, and stage 4. But I found that this X-ray and clinical presentation do not coincide always. So you can see the inner lining is getting damaged. So the management is exercises and strengthening and stretching exercises. And if early grade 1 and 2, then the exercise is good enough to relieve the pain and symptoms. NSAID should be used judiciously. Though glucosamine and chondroitin are used, but they have got doubtful value in recent researches. Duloxetine is, as I said in the fibromyalgia also, duloxetine is added to reduce the central and sensitization. And you often give intra-articular depomedrol, but there are regenerative therapies like platelet-rich plasma autologous, that's to take blood from the patient, then centrifuge, and the precipitate, the platelet is injected into the joint. Though viscosupplementation has been a treatment for a long time. What we are interested is getting a long-term relief so that the physical therapy can continue and which can reduce or stop the progression of the disease. So radiofrequency of the genicular branches, these are the 3 genicular branches for each knee joint, like they are located here, and you can see them both in ultrasound or in the fluoroscopy. We give a diagnostic block when you inject each one of them and see if it gives pain relief, then you do radiofrequency ablation. So that gives a long-term relief. And I've done a lot of patients who have failed knee replacement surgery, or patients who are not fit to undergo the surgery. This is the best alternative, though it is the problem remains, but the sensory stimulation is stopped. Radicular pain, which is very common, is that we need to jointly treat the impact of pain on the physical part of it. And so, see, when there is a disc prolapse, depending on the grade, and most of the time you see the symptoms will be irritation in the initial period when the nucleus pulposus escapes through the damaged or torn annulus, and that comes out and irritates the nerve. That is cause of the typical neuropathic pain. But as if the pressure goes higher and higher, you will get the patient will get numbness, and if it is too much, then you get weakness of the muscles. So what we do normally is we give transforaminal epidural block. We reach to the foramen of the affected root under fluoroscopy and use a contrast. You can see the flow of medication there, and use depot medications which relieves the inflammation and pressure over the epidural canal. And most of the time it works. And one of the common cause of low backache is lumbar facet joint arthropathy. And there is a pain and tenderness in the low back. And there is a stiffness, morning stiffness when the person wakes up in the morning, his whole back is stiff. He has to take some time before he can move. And the maximum pain is in hyperextension. So the main causes of is osteoarthritis, facet degeneration, and sometimes facetrum injury causing that one. So what we do is we denervate the nerve supply of the facet joint. The main supply is medial branch block, median branch, which comes from the same level and one from the above. We reach there under fluoroscopy, and this helps us diagnose. This is called spotty dog appearance. When the eye of the spotty dog, will be somewhere here. We reach there and give a medication. See, this is the spotty dog appearance. You see the ear. This is the dog head. So you reach to the eye level and give a block. And if the block confirms the pain relief, then you do the radio frequency ablation of those nerves. This is the radio frequency generator. This causes thermocoagulation and gives long-term pain relief. Sacroiliac joint is another cause of back pain, and this is one of the most underdiagnosed problem. 25% of people, and now the data is coming that more and more number of people with low back pain, the root cause is sacroiliac joint. The sacroiliac joint in the elderly group, it is osteoarthritis, the arthritis, and sometimes it is because of the ankylosing spondylosis, but mostly it is because of the loosening of the ligaments that is supporting the joint. That's why they get least pain when they're lying down. When the sitting position gives the maximum pain, the pain not only in the back, low back, it goes down to the posterior thigh and sometimes to the leg. And if you get the pain in the groin region, that is confirms that which is a supply from the L1 and L2. But if you get sacroiliac joint, it will give you pain in the groin. And there are provocative tests. So you all must be knowing that to confirm that it is sacroiliac, you stretch the joint and different postures. The treatment is to reduce inflammation by injecting corticosteroids into the joint under fluoroscopy. Some people do with ultrasonography, and but the best result is with the fluoroscopy because I have seen a lot of failures of sacroiliac joint injection done other places. So we would like to, when it is in doubt, use a contrast to see the spread of the contrast along the joint. So when it is a dysfunction or a hypermobile sacroiliac joint, you need to support the joint with the sacroiliac joint belt. That's advised for 24 hours for 3 months, except when you are taking shower, and that usually stops the pain. In 3 months' time, they get fused again. And these are the exercises. And if the injection confirms that is sacroiliac joint the source of pain, but it doesn't last long, then again you denervate this acroiliac joint through with the radio frequency rhizotomy. So you go enter to this, these are the nerves carrying the sensory supply to the spinal cord. You reach them, test them for both sensory and motor sensations. And if you confirm that you are not in any other place, then you denervate with thermocoagulations. Plantar fasciitis is a very common place. I think this is how the stretching of the plantar fascia, and that can cause problems not only in the pain in the foot, but also can affect knee and even up to the hip joint. So generally, this is your area where you provide different physical therapy and after the inner sole correction. And in inner sole correction sometimes gives corrects this deformity. Otherwise, you can go to this ultrasound guided injection into the attachment of the plantar fascia. Frozen shoulder is very common, particularly in diabetic patients. So in my earlier practice in pain, then we used to give general anesthesia and forcibly open the joint. So and once the joint is free for a while, then physiotherapy can be done, exercises be done. But today we have technology, we do denervate or we block the sensory supply. This is how normal capsule, and this is the thickened capsule, inflamed capsule. We go to the block the supraspinatus scapular nerve that is supplied to the shoulder joint, and the block is given ultrasound guided, and that gives a pain relief that lasts about 2-3 weeks. I tell the patients that within these 2 weeks and these patients start moving the arm just immediately after the injection, and they feel happy. Then I said, you do move your shoulder as much as possible within these 2 weeks, and most of the people, they get well with this one. And thank you very much.
Thank you, Dr. Chaudhary, for elaborating on each and every joint almost. And we do get a lot of patients which get their treatment done, and then also they do come to physiotherapy. But yes, it has summated that I feel that interventional management along with the physiotherapy, as you said, goes a long way in the patient's complete rehabilitation. So thank you so very much for elaborating on the topic so beautifully, covering all the things. So now, thanks. And now I invite Dr. Kanisha Mukherjee Pandey from UK to speak on the role of corticosteroids injection in chronic pain management. In UK, it is an extended scope of physiotherapy. Dr. Kanisha has done his bachelor's from India. Thereafter, she did her MSc in advancing physiotherapy from Coventry University. Thereafter, MBA in healthcare management, again from Coventry University, and then diploma in musculoskeletal medicine from Royal College of Surgeons. And she is proficient in various physiotherapeutic techniques, maybe Mulligan's, taping, acupuncture, cadaver training, soft tissue release, osteopathic training, and many, many more. So without taking much time, Dr. Kanisha, I would like to invite you to, we heard Dr. Chaudhary, but how physiotherapists there are offloading the surgeons, the consultants, and they are taking this as an extended scope. So thank you so much for joining, and kindly over to you.
Thanks for the invite, Dr. Seema. I'm just going to share my screen now. Hello, everybody. So, okay. So can everyone see my screen?
Yes.
Okay, so hello everyone. I'm Kanisha. I'm a physiotherapist working in the UK. I would like to talk today about the role of the corticosteroid injections in chronic pain management and basically its use as an extended physiotherapy scope in the physio clinics. So I'll just talk a little bit about me. So I'm an advanced physiotherapist practitioner. Currently, I'm working in GP practices for the NHS, managing the musculoskeletal caseloads. So basically taking over the musculoskeletal caseloads from the general practitioners. My role involves using specialist referrals, imaging referrals, physiotherapy management, and using extended scope physiotherapy skills like doing corticosteroid injections and also independent prescribing. So I would just like to just explain what are corticosteroids. So they are a class of steroid hormones produced by the adrenal cortex and transported to the circulatory system to target cells to regulate physiology and behavior. So there are the mineralocorticoids, for example, the aldosterone, which help in the regulation of blood electrolyte levels. And then there are the glucocorticoids, which are essential for life, stress response, the fight or flight responses, regulation of inflammation, gluconeogenesis, immune response, and anti-allergics. And the synthetic analogs are available as the hydrocortisone and the prednisolone. So application, this is what mainly is applies in our practice. So they can be used for various musculoskeletal disorders. They mainly help with management of pain and inflammation, especially when other conservative options are not helping. They are generally used for anti-inflammatory, generally used for inflammatory conditions involving synovial structures such as bursa, joints, and tendon sheaths. And I would like to stress that mainly in my practice, I would use it as an adjunct to physiotherapy management, just to give the whole holistic package to the patient. So these are the corticosteroids normally used. So depomedrone is a very commonly used one. And then there's the hydrocortisone as well, which I commonly use in my practice. The clinical applications I have discussed previously, mainly for chronic arthritis or acute flare-ups, capsulitis, bursitis, tenosynovitis, and tendinopathies. So I think it's quite interesting to understand how these injections work. I will just explain a little bit about it, which helps us understand how it will give you pain relief. So when there is a tissue injury, there is degradation and lysis of the cell membrane. And in response to the phospholipase enzyme, there is the release of arachidonic acid. And this starts the inflammatory cascade. Now there is the lipoxygen is released, which helps with recruitment of the white blood cells to the damaged area. And then there is the cyclooxygenase, which causes the release of the prostanoids, which are the prostaglandins, and thromboxane, which causes the symptoms of inflammation and pain, all the redness, edema, inflammation, all these symptoms. So what the corticosteroid injections would do, they inhibit the phospholipase action. So if we see, it's at the top of the chain of the inflammatory cascade. And now what the NSAIDs would do is they inhibit the COX activity, which is slightly at the bottom of the chain. So the corticosteroids would be more effective than the anti-inflammatory agents. So just go to my next slide. So the effects on the tissue, so basically all the aspects of inflammatory response are depressed. So the acute symptoms can be benefited. So the reduced pain, heat, redness, swelling. Then in the chronic cases, the proliferation and remodeling is affected. So that we should observe caution in acute inflammation and soft tissue injuries, because we do want the inflammatory response to take place. We do want the protective aspects of inflammation, and there might be a delay in fiber formation. However, in case of acute bursitis or tenosynovitis, this wouldn't apply. So they would benefit with the injections. In the chronic inflammatory phase, the balance of collagen synthesis is disrupted, with the inflammation and proliferation continuing side by side. So now how the injections can help is they can benefit with reducing the low-grade inflammatory component and helping with pain relief and relief with inflammation. So there are some side effects. I will quickly go through. I think the main one to watch out for is infection. So we should give good safety net advice after the injection. There can be some increase in symptoms, maybe a little bit flare, post-injection flare, and we need to be aware of possible tendon rupture. So we have to choose our patients properly, not the acute ones. And the side effects, the main ones to watch out for here would be have anaphylactic shock, impaired diabetic control. In case of people on long-term steroids or in high doses, immunosuppression and things like that. So the contraindications, the absolute contraindications would be patient not consenting for an injection. So it's very important to have that discussion with them and explain them how it might help them. And if they have an active infection going on, or if they are hypersensitive to a local anesthetic or steroid. The cautions, basically in these conditions, we have to weigh and try to have a discussion with their doctors or try to have a good understanding of their past medical history. So in terms of local long-term steroid usage, recent trauma, people on anticoagulants, people having poorly controlled diabetes, COVID-19, anxious patients, we need to be a bit careful when using the injection therapy in these kind of patients. So I would like to discuss some studies which show the efficacy of corticosteroid injections. Mostly these are relevant to how they would be used and benefited in chronic pain management. So for knee arthritis, the injections, they showed a superior effect on pain and functional outcomes in short term. However, treatments such as physiotherapy and NSAIDs showed more beneficial effects with long-term follow-up at 26 weeks. This is from a systematic review of RCTs. So I think it is important to understand how a combination of these two approaches would help in giving a more long-term impact to in the patient management. Also, there were improvement in pain scores and functional outcome in one RCT from 2018 up to 24-week follow-up as well. There's another interesting one, the one at the fourth one, which showed that the combination approach of corticosteroids and physiotherapy was superior to either treatments alone and produced better outcomes for patients for subacromial bursitis. Now, this is a new study from 2023, and it shows just how these two interventions together, they can give a lot more benefit. And this is where the importance of physiotherapy management comes into place. Also for conditions like greater trochanteric pain syndrome, they showed better outcomes as compared to the only home training, shockwave therapy, and usual care. Also for in case of back conditions, radiculitis, secondary to disc herniation and spinal stenosis, there is good evidence for use of steroid injections and local anesthetics. So I just wanted to discuss how I used, I have in my practice used the corticosteroid injections in conjunction with physiotherapy management. So I would just discuss a shoulder case that I have seen recently in my practice. So basically there was a 55-year-old woman who reported to my clinic with a 6-month history and worsening right shoulder pain with discomfort and stiffness. She also had trouble sleeping on the same side. She was experiencing significant trouble with her DIY activities. She loved to paint and, do all these things and daily living tasks as well. So her physical examination revealed a reduced active and passive range of movement of the shoulder joint with a hard end feel, as well as a capsular pattern of movement restriction, and it was consistent with a frozen shoulder diagnosis. She had type 2 diabetes, but she was generally in good health. It was well controlled. Her job involved working as a nurse, so she was doing a lot of manual handling activities at work. So we started with some physiotherapy rehabilitation and some analgesics, which she was already prescribed to begin with. Despite these measures and trying them for a good few weeks, she was still having substantial discomfort and functional limitations. So a subacromial corticosteroid injection was then suggested to her to treat her pain, because the pain was the main factor which was affecting her recovery, and also to help to improve her range of movement. So after a discussion, she consented for the injection and she tolerated it well. She was asked to relatively rest the shoulder for a week and then start and focus on the physio rehab. So on her 2-week follow-up, she improved, she reported reduced pain and improvement with daily activities. She had pain-free movements to an extent. And so with these better outcomes, she was advised to continue with her physio. On her 6-week follow-up, she had remarkable improvement in terms of pain and range of movement. She was able to get back to her hobbies, her DIY activities. It was important to consider that she was diabetic, so the antagonistic effects of corticosteroids on hypoglycemic medication was taken into account. We had a good discussion of how there might be a likely increase in her blood sugar levels, and she was advised to get in touch with her GP if her threshold level was breached. However, there were no side effects seen in her case, and so there are obviously lots of more examples like these, but when you use these skills in the physio clinic, I think as a combination, they can work well. They might not work well in some cases, but it's just to get that initial pain relief and improvement in symptoms so that we can focus more on the physio management. So yeah, at the moment, I'm training as a non-medical prescriber, which is also used as an extended scope skill for physiotherapists in the UK. I think it's a useful skill to have in the advanced practice toolbox for physios. It was introduced in 2013, and it was a huge step forward for the profession, also giving us some level of increased autonomy. Generally, it would help in delivering a complete package of care along with physio. Also important to have more focused conversations around condition management. So when you are dealing with all these aspects and you are obviously reducing waiting times, giving more enhanced practice, which might be linked to higher satisfaction rates. I think also one of the really important things we physiotherapists can get engaged in is having a more effective approach with prescribing, especially with opioids, because there might be addiction and so many other things and negative factors which are linked to them, and encouraging more non-pharmaceutical approaches such as acupuncture and exercise, and people getting control of their pain and understanding how it affects them. Therefore, giving them a more holistic care. Also, logistic aspects of it, such as when you are prescribing an injection, when you are giving an injection in an injection clinic, there are lots of things like getting the injection prescribed by the doctor. So if you are able to prescribe, it's just reduces waiting times, and it's just a more logistical benefit for physios. So obviously also, physiotherapists, if they would have already existing physiotherapist assessment skills and clinical judgment, so these things can always be used to use the extended scope skills in a more efficient manner. And obviously, we need to consider the benefits versus risk of prescribing when we are looking into that. So I just thought it's good to share the WHO analgesic ladder, which I always refer to when looking into prescribing for any patients with pain. So start with non-opioids, such as paracetamol or NSAIDs, and add in an adjuvant if needed. Then if these things don't work, then we would look at prescribing weak opioids, with or without an adjuvant. And then if these things don't work, then we would look at strong opioids and a non-opioid medication with or without an adjuvant. So the drug types which would be used for chronic pain would be the NSAIDs, the non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen. Then there are so many different kinds of opioids. Then antidepressants such as amitriptyline, muscle relaxants such as diazepam, serotonergic compounds, anti-epileptics such as pregabalin, gabapentin. Then there's also the option of using corticosteroid injections. So I would just like to conclude that the injections, they show a lot of short and medium-term benefit in pain and disability. And this has been demonstrated for a number of musculoskeletal conditions. And this is where, because they would give an initial short-term benefit for 2 to 3 months. And this is where a combined approach of using your physio and self-management options can help with getting more longer-term outcomes. There is also increased evidence when injection therapy is combined with a carefully executed progressive loading and exercise program, the need for repeated injections is reduced. So obviously with more injections, there can be more side effects and more risks. So at the end of the day, it's all about having to rely less on them and promoting more patient holistic care. So there are also alternative injection therapy options such as the hyaluronic acid or the platelet-rich plasma. However, the steroids still have a prominent place in the management of these chronic pain conditions. And there's the option of landmark guided or the ultrasound guided approach. So in case of landmark guided, which is what I use at the moment, I'm not trained in the ultrasound option. So it's more simpler and cost effective when using in clinic, provided you have the sound anatomy and the application of skills for some areas. In case of ultrasound guided, it has a great role for deeper structures or targets which are closest to large vascular structures. So it is more, it's especially like hip joints and all. I wouldn't do a landmark guided one. And also when landmark guided injections has failed. So thank you all for listening to me. It was nice to speak to you today.
Seema ma'am, please unmute yourself.
Oh, yeah, sorry. So thank you, Dr. Kanisha. Yes, we can relate very well with the evidence what you put across. In Indraprastha Apollo Hospital, we do the same, having patients with coming after their injectables and stuff and coming for their rehab, and the outcomes really, really improve. So this is a common practice here where we all work hand in hand. And thanks for that insight. Without taking much time, I believe we have now Dr. Hiten Dave from US. I would like to introduce him and his topic. Today, he's going to talk on chronic pain management using vagus nerve activation. It is an innovative hands-on technique, which I would like to introduce Dr. Dave. He is up early in the morning with us. Thank you so much, Dr. Hiten, for joining us. He graduated in 1984 in physical therapy from Northwestern University, Chicago, Illinois. Thereafter, he opened his private clinic in 1985 in Pleasanton, California. And as on today, he has 5 clinics in San Francisco region of California. He was always interested in treating chronic pain. He himself had little kind of accident, and thereafter, his quest for learning hands-on techniques started with being first batch of students of John Burney's PT in 1985, who coined the phrase myofascial release. So we are lucky enough to have him here today. He took seminars from Dr. Lawrence John, an osteopath who started strain counter strain method. Physiotherapists can relate very well to it. He would like to share his knowledge acquired over these years with us for quick results in pain relief. So over to you, Dr. Hiten Dave. Please.
Oh, hello. Hi, everybody. Again, my name is Hiten Dave. I'm in Pleasanton, California since 1979, actually, but my practice started in 1985. So going back in time, yes, actually, my mother used to have severe migraine headaches. And so I kind of grew up watching that. And then, of course, I broke my arm, I got physical therapy. And then I got, a big believer in physical therapy. But strangely, all of my classmates didn't want to really treat chronic pain. They were into sports injuries and something, treating younger people. Excuse me. So I actually went more into the chronic pain side, and by taking courses from John Barnes and then of course from Dr. Lawrence Jones, that made a big difference. And then I learned more about the nociceptors, the muscle spindle, and trigger points. And then something strange happened. I accidentally went into the vagus nerve learning. And in school, we were taught about, we knew what vagus nerve does. It's more like a rest and digest type of, parasympathetic nervous system. However, we were never thought about exactly what it does. It actually is vagus nerve activation is actually creates a an anti-inflammatory reaction by releasing the acetylcholine. And so, I know it's actually an anti-inflammatory reaction when you are in the rest and digest mode. And so I learned all those things. And then I took a lot of courses from chiropractors, from neuropsychologists to learn about how the brain works. And so again, I believe that there are two things I believe in. That first of all, we should do no harm to the patient. So any technique you use, it should not be harmful to the patient. And if you cannot help your patient, it's okay. But if you harm the patient, it's not okay in my books. So my guarantee, well, it's not a guarantee, but it's actually something which I feel that when a patient comes to me, in my clinic, I had to get them out of my clinic at least with 10 to 15%, pain relief. That's something which we owe them. And so I come from a different background. I mean, compared to the other speakers, in California, we don't have the luxury of getting involved in any kind of injections. We cannot do injections. We cannot discuss medications. So we are very limited, and in that limited form, we have to earn a living. So obviously, we only have 45 minutes, half an hour, 45 minutes, with the patient, and within that time, we have to get them better. So it's a big chore, but it's very exciting because when you see the results, it's so quick. So what I've done is actually created my own little, like a course, like a seminar, which I'm teaching my own staff right now. I'm calling it Physio Hack, meaning I believe that every physical therapist or anybody who's treating patients should have at least a few techniques, few ideas in the pocket. And I believe that one technique can work with one patient, but it may not work with the other patient. So we need to have a plan A, plan B, plan C, and plan D. And everything has to happen fast. Everything has because people don't want to wait till tomorrow to get any kind of a pain relief. They want immediate gratification, and we have to provide that because that's why they're coming to you, and they have spent the entire day coming to physical therapy. And if you don't give them relief, it's not useful for the whole time being wasted, I guess. So that's why I got more into this. Then I did a lot of learning on the mechanoreceptors, the somatic mechanoreceptors, the Merkel's discs, Ruffini endings, Meissner's corpuscles, and Pacinian corpuscles. Learn more about the gate control theory of pain by Melzack and Wall. And so putting all those things together, I came up with my own, like a fusion of techniques, because as I said, that it has to be quick, has to be fast. And since, again, I'm going to bring to another level over here, since we are physical therapists over here also, I want to do a little bit more interactive. So I want to actually give you guys like a little demonstration. And if you guys want to all stand up and see if you can actually reach and touch your toes. And somebody who is not able to touch their toes, we have a jackpot. That's the person I want to actually let them know that how this simple thing which I'm going to show you is actually going to have you go further down and touch your toes further down. So if you're ready to do that, let me know. So when you stand up, what you do is very gently put your hands in the front of your thighs and see if you can very gently go down and see how far you can reach down, going towards your feet. Now, say for example, if you're able to go below your knee, say in the mid shin area, stop over there, stand up again one more time, and this time move your lower jaw from side to side like that. And while moving your jaw side to side, I want you to go down again one more time and see how further you're able to go. So I can almost guarantee that it'll be at least 2 to 3 inches more than what you did before. And you guys can try it out or whenever you want to. Again, I don't do this as a treatment. I just show as a demonstration to all my new grad physical therapists who come to work for me. And they want everything to be evidence-based and everything. So I quickly tell them that, look, just stand up over here right now, see if you can touch your toes, move your jaw, and this is what happens. So what happened was is that you're moving your jaw, you're actually activating your trigeminal nerve, which is right at the trigeminal nerve canal at the angle of your jaw. And the vagus, the trigeminal, and the accessory nerve, they are not from the same origin. They're very close by, but they all three affect each other. So when you're activating the trigeminal nerve, you are creating a very like a overall relaxation activity by the vagus nerve, which reduces muscle tension and increases spinal flexibility. So this is a very small example I'm giving you. Another example I want to give you, again going back to the Melzack and Wall's theory of gate theory, and then also about the somatic mechanoreceptors. So, for example, say a patient comes with tennis elbow, and they are feeling on the side of the elbow, they're touching it, it's very painful. So, say on a scale from 0 to 10, they are at say 6 or 7. Now, what I do, so if you think about you're activating the muscle, so I have them bend their elbow, and I use like a reflex hammer or just tapping. I would tap on the biceps tendon and also on the brachioradialis, biceps tendon, brachioradialis. So I do that like 10-15 times. Then I have them actually turn the arm into, and then have them like have the wrist into extension, and then I tap on the dorsal part of the wrist with a reflex hammer, because basically the tennis elbow situation is because of the extensor carpi radialis brevis. So I usually do try to activate that, and by that time the pain level has gone to like 3 or 4. It's not totally gone away, but they actually are, they're getting this feeling that this guy knows what he's doing. So because within like a minute or 2 minutes, I'm trying to get the pain down. Then now I would do my traditional physical therapy. I would do some distraction of the joint, try to do some mobilization, then actually teach him or her exercises, because now they are going to believe in you and they will do the exercises which you tell them. Then I go over ergonomics, teach them about how to make changes in the way they are sitting. Also, how breaks every half an hour is going to be very beneficial. So all these things they are listening. They are listening because now they felt some pain relief. So now they're going to do what you actually ask them to do. So this is how you need to get them on your side. I feel that our patients sometimes, you teach them a lot of things, they actually don't end up doing things. But if you show them, if you make a little negotiated thing that, look, I'm going to actually get you some pain relief. In return, you're going to do things what I'm going to tell you to do. And because nobody likes pain, so if you teach them things to do at home, they are not in that panic mode anymore. Because pain does cause panic ideas, because now suddenly they're frozen, they don't know what to do because it's hurting, and it's also annoying. So if you teach them things to do at home, which will help them to get the pain down, that's another win-win situation. And so these are the things which I do, and I have, as I said, I created this this course. I'm calling it the Physio Hack, And I'm out going to come into India very soon. I've been invited by a couple of universities to see if there's an interest. So I might even actually end up going to these places, talking to physical therapists over there, and to see if there is any interest. And I feel that this mind body is techniques which we are using and which should be used, because again, as I said, in California we don't have the luxury of using everything else. We do work with a lot of physicians, and I was talking to Dr. Chowdhury about how trigger point injections, it becomes such an important thing if a lot of things have failed, and just to get the patient to the next level. And that's about it from me.
Thank you so much, Dr. Hiten. I believe it was just a tickler to the people to really understand that, yes, vagus nerve, how it can make the difference. And yes, this little hacks, as you rightly put, that your course name is Physio Hacks. So I believe it's just giving a tip of the iceberg how people can work on various things. And we all will agree that physiotherapists now are going in different ways to take care of patients' mobility, pain, and having other things along. So I thank you so much for sharing your thoughts on this. And now I would like to invite Dr. Pooja Chugh Anand, who is going to moderate the question answer session, and would request our listeners, if they have any questions, they can just put across. Dr. Pooja Anand has 8 years of academic experience in physiotherapy field. She worked in various positions in organizations and has executed administrative and academic policy at the best to run the departments of physiotherapy at various institutes. She's an enthusiastic teacher with passion for creating stimulating interactive learning environment with more practical applications of the knowledge. With various publications to her credit, guide many students, and she's been a guide to many students, recipient of many prestigious awards. We have with us Dr. Pooja to moderate the session.
Thank you. Thank you so much, ma'am, for your introduction. It was really nice to listening to all the speakers. In the chat box, we had 2 or 3 questions. I'll just take it up, and we have one hand raising by Raj Villamore. We will take it from him also. Tanisha, this was for you, but I hope you have answered it. Do you take help of imaging? That
Yes.
was one.
Yeah.
Do you take help of imaging? That was one question. And another was, is FCP first contact physio?
Yes, so FCP is first contact physio. So it's that initial service before they go into a secondary, like orthopedic referral or neurologist or physiotherapy, like a full course of physiotherapy. So instead of going to in England, if you have a problem and any health issue, you would first go to your GP, that's the general practitioner. So FCPs are the advanced practice physios who have taken over the MSK caseload from the general practitioner. So we are the ones that seeing them as the first contact instead of the general practitioner. And then, you offer them the initial advice, and you offer them if they need an injection, usually they would be done by the doctor. So the physios have the opportunity to do it if they are trained, or if they need medication, if they need the physiotherapy rehab. So it's like a first stage of assessment, diagnosis. And yes, if we need to do any blood tests or any investigation,
I don't know what that was.
such as imaging, we would do that as well.
Okay. Mr. Raj, you wanted to ask your question. Can you please unmute yourself now and ask?
Hello, can you hear me?
Yeah, we can hear you, sir.
Yeah, I just wanted to get a sense as to how to manage chronic pain in the context of someone who has myasthenia gravis. Thank you.
Thank you. Shruti sir, if you can take up this question.
Sorry, myasthenia gravis.
Yes, sir.
I have no idea of any
Okay.
specific treatment unless there is a spasticity. Myasthenia gravis is actually a relaxed muscles. There is a
Yes.
weakness. So I only can feel that logically acupuncture can help with stimulating the neuromuscular endings. That could, but I'm not sure.
Okay.
Okay, thank you. Thank you.
If somebody else would like to put light on that, or if we have a next question, what is the line of treatment for pain referring due to visceral organ abnormalities? Dr. Hiten, if you can pick it up. I will repeat, what is the line of treatment for pain referring due to visceral organ abnormalities?
I can answer that.
Okay, sir. Yes.
Viscera means that comes, this a visceral pain can come from different places. If it is suppose a pancreatic cancer, the symptoms will be different. So usually you give sympathetic blocks. Sympathetic, there is no somatic nerves. There is only the sympathetic nerves, and some places like heart there is a parasympathetic nerve supplying there. So we give sympathetic block and neurolysis. Like suppose you had the CA pancreatitis with the severe pain in the upper abdomen, you would go to the sympathetic plexus at L1 level, T12 L1 level, or if it is higher, you go to celiac plexus and then we do neurolysis after giving confirm with the block. And for pelvic area, we have got different sympathetic channels like splanchnic ganglion. We have ganglion impar, depending on in the lower pelvis, we give ganglion impar block, and in the upper pelvis, we give lumbar sympathetic, splanchnic nerve block. So these are sympathetically mediated pain, they are not somatic pain.
Yes. Thank you, sir. We have another question. What will be the best and long-term pain relief intervention for shoulder pain, post-dislocation and communicated fracture in an elderly female with osteoporosis? I'll read it again. What will be the best and the long-term pain relief intervention for shoulder pain, post-dislocation? Yes, sir.
No, you have to fix up the disease first. That means
Yes,
you have to fix, and
treatment has to be given.
Surgically it has to fix, then immobilize.
Yes.
With
Yes.
plaster. So and for the pain relief, as I said, suprascapular nerve block can help to relieve the pain. Suprascapular nerve block, because it's a injury to the shoulder. If the capsule is damaged, then there is no intra-articular injection.
Okay. So how, this is from my side, like how cognitive behavioral therapy in pain relief, chronic pain relief is giving good results, and it is helping the patients in the treatment.
Do you want me to answer that?
Yes, sir. Open to you.
No, as I said, that the impact of pain is on body and mind. And a few of the speakers spoke about how to get the confidence of the patient by his management. See, there are certain complementary therapies where the patient contact with the physician or therapist is longer, like massage therapy or cognitive. So that creates confidence and the patient starts relaxing. Cognitive behavior therapy is releasing the stress after your come out with your problems and you found the solution. So that is cognitive behavior therapy. It can be in the form of biofeedback or counseling, in the form of counseling. And last thing is medications.
Medications. Thank you so much. I hope these are the questions what we had for the panel. Seema ma'am, can we have you?
Thank you. Yeah. Thank you, Dr. Pooja. I believe we are overseeping by 20 minutes, but I thank everybody, our esteemed speakers who took out their time from their precious schedule to be a part of this webinar and share their rich experience and knowledge on the subject. I would like to express my gratitude towards Dr. Anupam Sibal, the Group Medical Director of Apollo Hospitals and the President of GAPIO, for his constant support and vision for enabling such a platform which would help us break the glass ceiling and provide superlative healthcare services. Today, we have discussed as a multidisciplinary approach, as we have just heard Dr. Chaudhary answering a lot of questions and other people participating into it, so that we can really understand how together we can really help in pain relief. Lastly, I would like to thank all the members of the audience for their being a part of this webinar and making it lively one. All of us here during our interactions, during the question and answer, and I believe participating into it gives an insight that yes, this is a topic which touches many, but requires a lot of still work on it, or information how we can really help our patients. So with this, I would like to thank everyone to be in this webinar with us till this time, and we'll thank our speakers. Definitely joining us from UK, US, Dr. Adrian sending his the pain movement or his science, what he's teaching, the education. If you just type by Dr. Adrian Law, you will find that he has talked a lot on central sensitization. He's talked a lot on how we can control the pain. So as rightly said, cognitive behavioral therapy, we know a lot about mirror therapy working in hemiplegics and all, and stroke patients. So there is a lot to really work on it. So in the end, before taking much time, I would thank all the attendees, the speakers, and the organizers who have really helped us to put this show up. Thank you, everyone. Wish you a good night, a good morning, Dr. Dave and Kanisha. Thanks a ton for all of you being here and all the attendees for making this webinar a success. Thank you so much. Every quarter we come with one of the sessions taking to the extended scope of physiotherapy. I believe you all would agree that as UK has put it to physiotherapists to share the load and many more things as drug prescription and all. So it is really good that let's all work towards expanding our horizon and looking into it. Thank you so much. Good night and good day to everybody. Happy weekend. Thanks till we meet again. Thank you.
Thank you, ma'am. Thank you.